So the scope of what we'll talk about, hopefully, anomalous origin from the left coronary from the pulmonary artery, anomalous origin of the right coronary from the pulmonary artery, anomalous origin of the coronary arterial branches from the pulmonary artery, left coronary from the right sinus, right coronary from the left sinus. The origins are in congenital heart disease, transposition, tetralogy, truncus, and other miscellaneous conditions. So normal coronary imaging, we've showed you how we do this. You can also look at color flow. Color flow is important because it gives you the direction of flow in the coronary arteries. You don't want to make a fool of yourself and see something like this and call it a coronary artery, because really what it is, it's the great cardiac vein that Steve showed us so beautifully on his MR. So there it says GCV, and as you see it flowing down away from the heart. So this isn't an anomalous coronary. It passes the entrance of the left coronary artery and joins up with the oblique vein of the left atrium to form the coronary sinus. So that's something that we saw on 2D imaging as well. Now, again, just like some of the other conditions, I like to look at the general to the specific. And so for POLCA, I call it POLCA. It stands for pulmonary origin of left coronary artery. It's got nothing to do with the DONS. I'd like to think of looking at the history, the physical, and the ECG. It's amazing how there's still physicians that can diagnose anomalous left coronary artery by electrocardiography in children. Cardiomyopathic appearance of the left ventricle and mitral regurg. I think you'd be lucky to see a patient who is asymptomatic who doesn't have those conditions. The coronary arteries, because we're dealing with a fistula and the flow is from the right coronary into the right coronary is usually larger than the left coronary artery, and that's not the usual rule. Coronary flow, because it's a fistula, can be seen throughout the myocardium, and there's retrograde flow in the coronary circulation, and a jet can be seen entering the pulmonary artery. Until we got color flow, we were much less good at making this diagnosis. Direct imaging of the coronaries is the last and final thing. So here we go. This is a patient who has an anomalous coronary from the pulmonary artery, and you can see that the only part of this ventricle here that's actually contracting is the part that I highlighted. In the long axis is very poor contraction. There's mitral regurgitation. It looks like a cardiomyopathy. There's mitral regurg. There's dense echoes arising off the papillary muscles. There's rouleau formation in the left ventricle. And there's almost an aneurysmal dilatation of the apex of this left ventricle. The flow, when you lower the color flow to 31 on the Nyquist limit, you can see the poor flow, with this being inflow into the ventricle and that outflow. And of course, there's an area in the middle where the red cells are just churning around, looking for a potential to form a little thrombus. Here's the same patient showing the mitral regurgitation. And you'll see this flow in the coronaries. This is, I think, also one of your MRI pictures. And I'll just let it play in. You see there's the coronary. You can see the flow in the coronary is coming blue. There's also a small pericardial effusion, which appears to be red and blue. But look at next to it, you'll see the blue flow of the flow going in the wrong direction. And here's red flow from a circumflex going towards the main coronary artery. So the flow's going in the wrong direction. And when you look on the apex of this patient, here's a large anterior vessel like this one over here, which is probably the LAD. And the flow in the LAD is going in the opposite direction from where you'd like it to go. So just simply finding something like that should tip you over to the fact that you're dealing with a serious problem with the rest of the findings. And this isn't just a simple dilated cardiomyopathy. So I didn't mention about the history, but I think that it's very important to emphasize that most of these patients with anomalous coronaries, the way the patients present is they present with gastrointestinal symptoms, either colic or reflux. Now, this is the current diagnosis. you know, and that the kids, the maximum activity for a newborn infant or for a young infant is feeding. And so they feed, and when they feed, they use up a lot of effort, and they then get angina. And when they get angina, of course, then they respond like all babies by crying, and they put up their legs and they pass gas, and everybody thinks they got colic. And 99.9% recurring of the time they're right, it's just colic. But that's exactly how these babies present. So, you know, if you're pediatricians and you're in that area, you have to know about that. And I know that you're going to see so many patients with colic, it's really difficult to make the diagnosis, but it's certainly something you have to be suspicious about. So here again is the great cardiac vein and the coronary artery. And the coronary artery flow and the flow in the great cardiac vein are going the same way. Now you must be careful when you look at a picture of a coronary, is to judge where the flow is going, because often when the myocardium squeezes in the normal case, it takes the blood that's in the myocardium and squeezes it back into the coronary artery. So even in a normal coronary artery, there may be a little retrograde flow in early systole. And the flow into the left coronary artery is normally a diastolic phenomenon. So here again is abnormal flow, and you can see this flow coming the wrong way again in the left anterior descending and entering the pulmonary artery. And again, I'll point out to you that the Nyquist limit is only at 34 centimeters per second. That's a particular problem for the I-33, which defaults to a nice high frequency second like you'd like to use in other conditions, and you have to remember to lower the Nyquist limit, otherwise you can miss the diagnosis. So, and here is the definitive diagnosis. You can see the left main coronary entering the left facing sinus of the pulmonary artery. Here's the circumflex, here's the left anterior descending, and here's this coronary cusp, and there it enters right there. And of course you can put color flow on the system, and you can see the flow coming up the circumflex and going into the pulmonary artery. The left anterior descending is not that well displayed in this flow. So I think it's a pretty easy diagnosis. Here's another one. And that's the short axis parasternal view. You can also put it into this long actus ductus cut, and this is a patient that I actually catheterized in my early days as a cardiac cath man. And this is a patient with an anomalous coronary with a balloon catheter in the pulmonary artery and just a small amount of filling of this anomalous left coronary. Now the only point in taking this picture is you show that if you put the echo in the same projection here, you can see the flow from the coronary artery coming into the pulmonary artery. This is where the left main coronary artery lies. So it's an easy diagnosis to make. I think it should not.
That is particularly useful in ones where the coronary comes very close to the aorta.
Yeah, I'm going to go through that right now. So the next thing I wanted to discuss with you is not all coronary arteries are this classical and typical variety. And in fact, the coronary artery will drain anomalously to a variety of sites, and not many people have got them. Well, they can drain around the entrance of the pulmonary artery, but they can also drain distally to the origin of the right coronary artery and the origin of the left coronary artery. And there was a wonderful paper published by Pascal Voyer which showed this, and here is an example of what happens when it drains to the right coronary artery. This is an anomalous left coronary artery draining to the pulmonary artery, but it's complicated by the fact that it runs an intramural course in the aortic wall at this point. So if you're very unsophisticated, you say, oh, well, that's where it's draining in. And it's clearly not draining in. And the way to operate on these patients is to open the aorta and marsupialize the coronary and then ligate it up here. And if you do that, none of you are surgeons, and neither am I, but if you do that, you come out with a live patient. And if you simply take the coronary artery off here because you think you have to transplant it, or take it with a button, you get into all kinds of problems. So you have to learn how to do it, and there are obviously a number of techniques. The left anomalous origin from the left doesn't seem to run this intramural course, but then it's far away from the aorta. But you have to watch out, because sometimes these coronary arteries are not draining to the classical site where you think they're draining. And there's a variety of techniques for lengthening the coronary. Here's one where he's made a ring, and then he sews the ring as a large tube and then anastomoses the tube to the aortic sinus. So here's a post-operative example, and almost immediately post-operatively you see the left coronary artery with prograde flow, and you see the relationship between right coronary artery incisor and left coronary artery incisor change. The right coronary gets smaller and the left coronary artery gets bigger, because the flow is going in different directions. And of course you can see the button where the surgeon has sutured this little button of pulmonary artery tissue, in much as he does with an arterial switch procedure. And there's of course the button shown by the arrows. Excuse me. And there's the mitral regurgitation, even after operation. And this is 1 year post-operatively. And I showed this to Mark Friedberg, who's not here at the moment. Oh, here you are. Sorry, Mark. Oh, you're not Mark Friedberg. Keep your hand down. Okay, that's better. Oh, thank you. But this patient has still got a lot of fibrous tissue in the left ventricle, albeit that it looks like it's working well. So I don't know. They get better. There's no question about this, and there's remolding and all sorts of things, but they don't get 100%. So this is a pulmonary artery from the right coronary artery. It's less common than from the left. I call it porker. I'm always either dancing or eating. They may be symptomatic, they may not be symptomatic. And in fact, I'll show you one that was diagnosed after an ASD was repaired without catheterization. And here it is. And this is an injection into the left coronary artery. And you see there's the left coronary artery with the LAD and the circumflex. And then you see the anastomosis to the right coronary artery and its drainage into the pulmonary artery. Now, I don't know, perhaps because the coronary demand on the right side is not as high as the left, these patients are less symptomatic. And this patient then went to surgery and had the anomalous coronary artery transposed. Here's another example of an anomalous coronary artery with the flow coming into the pulmonary artery from the right coronary. Left coronary is normal. There's the left coronary up here. So, get carried away. It's a second example. I forgot to cut it down. Now, this is a coronary from the an origin of the left coronary from the right-facing sinus. This is a condition with a high incidence of sudden death. In fact, the first symptomatic episode may be sudden death in these patients. And the one important thing that perhaps we've contributed to in some minor step is that we have found this occurs in family members. Anomalous coronary arteries occur in family members. The people from Philadelphia wrote up a series of 5 cases with a family history of anomalous coronary artery of this kind. So if you find it in one family member, it behooves you to evaluate the family for the presence of this lesion. And just like it does in transposition, it may be fatal, may have syncope with or shortly after exercise. The coronary runs an intramural course. It crosses a sinus of Valsalva. It may have an great vessel course. And as Steve had showed, the origin may be slit-like, and it's often high, almost always high. And as I said, it runs an intra-arterial course. And here's a nice cartoon of such an anomalous left coronary rather than running from the right-facing sinus. The artist has not drawn it running an intramural course, and he's drawn it running a low course rather than a high course. In most of these patients, the coronary artery runs above the sinus of Valsalva here, so that all the surgeon needs to do is unroof it. If it's lying low like that, he can't simply unroof it. He either has to detach the leaflets from the aortic wall and reimplant them and put a slit over the place where it ran, or alternatively marsupialize the coronary, as I showed you for that anomalous origin of the coronary from the right pulmonary artery. Marsupialize this and make a second hole in there. Well, the normal life expectancy looks something like this. We know from the natural history studies that the life expectancy looks something like this. What do you mean, how do I know?
We don't even know what the prevalence is in the population.
I know. Wait a minute. He's right, of course. We don't know the answer to these questions because we don't know what. But if you plot the ones from the AFIP study, then you get. Yeah, I understand that. But the point that I want to make about this is not that that this is actually a reflection of numbers, but rather a reflection of what happens. Because if you look at the AFIP study, there is, even in that a group with anomalous coronaries from the right, from the right, or the left from the right from the left sinus, this one here, right from the left sinus, that has an incidence of sudden death. Now, it's nowhere near the incidence of sudden death from the other side, but it's of course a worry, and it's a worry particularly for us Americans, where the lawyers are very active about obtaining a retribution. And I think that without knowing what the natural history is, there is now a direction towards operating almost on all of these patients that are discovered. And that's the point I wanted to make.
So
now,
we don't know what the natural history of the operation is.
That we do not know that either. I know, but you don't get sued for doing a good operation. Anyway, this is, I think, the origin of sudden death. There's two things that can occur. Of course, during exercise or after exercise, there are changes in the cross-sectional area of the aortic root. The aortic root and the pulmonary artery can change their size in up to 17% during the normal stroke volume. And so with exercise, with the increase in cardiac output, these vessels can get much larger. And when they get much larger, if you've got an anomalous origin of a vessel, it may get compressed between the two great vessels. I think, to my mind, the much more likely is that there is root forces on the aorta, and with the intramural course, that there's compression. The reason I say that is I've seen Dr. Gaetano Tien's histology, and the interesting thing with intramural coronary arteries is that when you look at them running through the wall, instead of being spherical, because they run through the wall, they change their caliber so that the caliber is more oval or ellipsoid. And then, of course, any minor change in vessel diameter may cause kinking of that vessel. I wish I had those pictures, but Dr. Tien is very, very specific about not letting you have any of his pictures. So Mark doesn't have any of his pictures either. So here is a vessel in an anomalous coronary artery that's running a course, intramural course, between the aorta and the pulmonary artery in transposition. Okay, and here you see this intramural course coming off the wrong commissure here and running to the left side with a normal right coronary artery. And I think that there's certainly a lot akin to this anomalous origin. And here is, people tell you what's the difference between a physician, a psychologist, a psychiatrist, a surgeon, and a pathologist. The answer is the psychiatrist knows nothing and does nothing. The physician knows everything and does nothing. The surgeon knows nothing and does everything. And the pathologist does everything and knows everything, but too late. And so this is a patient with an anomalous coronary artery that arising off the wrong sinus. Here is the right coronary sinus. Here's the right coronary artery. Okay? And here is the ellipsoid look at the origin of the left coronary from that same sinus, running perhaps a little high. It's certainly running above the sinus of Valsalva. So all the pathologist did is he simply unroofed it. And so what you're looking at here is a successful operation, but too late. And the sadness about this particular patient is he was my patient some 20 years ago, and he got an echocardiogram from me, and I said it was normal. And the echo was normal. I just didn't look at the coronaries 20 years ago like I look at them now. And so it may be even longer, 30 years ago. And he had an intramural course of his coronary that looked something like this on the echocardiogram. And here you see the origin, the intramural course, and the left anterior descending, the ramus intermedius, and perhaps just the origin of the left circumflex. Here's another look at the intramural course here. And of course, if you do coronary flow, you'll often see a high velocity of flow within this coronary system. Now, everybody will tell you it's coming from the wrong sinus, but where's the sinus? Do you see the sinus? There's no sinus here because this is a high intramural coronary, and the sinus is below the place that we're cutting it. So if you want to see which sinus it's coming with, you have to go down with your scan, find where the sinuses are, mark where they are in space, and then move up to the coronary, because the coronaries are frequently high in this condition. Here's an origin of the right from the left sinus, again running an intramural course. This young man that you see here, who is an intramural course, look how as the vessel runs through the wall of the aorta, it changes its caliber. This young man had only one problem. When he swam, if he was a swimmer, when he dived in the water, he fainted. And so he got this echo, and he actually had this successfully unroofed at our institution. Now here it's running a little lower, and in fact, because the heart not only twists, but it goes up and down, you get to see the sinus of Valsalva when you don't see the intramural coronary, but I think you can clearly see the coronary is arising off the wrong sinus here, so right off the left sinus. Okay, I wanted to see if I have one here that I need to show you. So that's enough of this. This is something that we see as a curiosity very frequently. It's a normal finding in a small number of adults, and that's that the vasa vasorum sometimes of the vessels will actually enter the pulmonary artery, and these are small coronary fistulas. Sometimes they can sound like a small patent ductus, or have patient with a continuous murmur, or perhaps nothing. Pardon? Usually nothing. They're interesting to look at. I think I have an angiogram of this for you to show you, and they occur on different parts of the, I didn't put the angiogram on here, but you can see this on regular angiography of the coronaries as well. Now, just a few words about coronary arteries in transposition. We have the master sitting right here, and I am his disciple in this area. So we see left anterior and circumflex coronary artery coming off there. This is a 15 megahertz high-frequency transducer, linear array vascular transducer, ideal for small infants. Produces high-resolution pictures, but even with the standard echocardiogram, you can see the bifurcation of the left coronary. You can see the normal right coronary, and the normal right coronary runs in the right AV groove and often has a dip in it and runs into the back of the sinus. And this is certainly my contribution to the paper by Pasquini and Sanders and others. And I have here from Mark Alpin's book a picture of what Steve showed us, a single origin from, do you call it from the right sinus, or you call it sinus 1? I don't like sinus 1. You're also not a sinus 1 person. Okay. Well, what did they call that? The Leiden Convention?
Yeah, Leiden.
Yeah.
I can never,
that's what I can't remember either. So I call this the right coronary sinus.
Yeah.
There's the right coronary, and here is this structure going around in a patient without transposition. And you see how this vessel, just as I didn't know that you we're going to show a picture, but just as you showed the picture, the coronary artery runs behind the great vessel. So what I didn't say is that the coronary artery runs behind the pulmonary artery. I said it runs behind the great vessel. And the great vessel could be an aorta, it could be a pulmonary artery. But a coronary artery that runs behind the pulmonary artery in transposition will look like this. Okay? And here are the 5 types from Pasquini's paper: normal coronaries, a circ off the right, which is much more common, a single right coronary artery, and here we have 2 types where we have this pattern. Okay? So if you can see this on an echocardiogram, you know you're dealing with one of these 2. Or rarely, you have the so-called double loop pattern, which will run like that, and the other vessel runs like that. Very rare, but certainly does occur. Other than that, in the normal or a single left coronary artery, the coronary arteries run in front of the great vessels. So if you can see that on an echocardiogram, it's very helpful. And here is such an example. Here's the circumflex coming from behind the pulmonary artery. Here's the aorta, and there's the right coronary groove. It seems to be draining from a single orifice. Let me show you some more pictures like that. Okay? When the vessels are side by side, this is a much more common origin. Huh? Now, the secret of looking for the AD, the anterior descending coronary artery, is to look forward with your probe to see whether there's actually a coronary artery coming, because when the coronary artery goes forward like this, it generally means that the LAD is arising there. There may be a dual supply. There may be separate branches coming off the aorta, a little conus branch. Some frequently have a different coronary. But when you see this, you can have to look and see whether this is just a lone circumflex or whether the anterior descending is coming off it. Here's a coronary artery, as I mentioned, side by side. And here's one where there are actually 3 vessels coming off those posterior sinuses, a separate left coronary artery here, and the circumflex and the right coronary arising from the same sinus, the posterior or right sinus here. Now, this is a patient that has a single coronary, and you can see the vessels are, again, much more side by side than they are front back. And here comes this coronary down here and running here, and here goes the circumflex, and here goes the left anterior descending. I'll take the labels off for you. So do it. I particularly like this technique. The technique that I'm using here is a slow motion capture of this by digital means. And I think you can see very nicely that that's a single right coronary artery. How they enter the sinus of Valsalva is often variable. They may enter as a single channel, and I think you showed one that entered as two separate channels. I just saw one in Children's Hospital in Los Angeles, identically like that. And
one of the MRs had that,
yeah, it's the MR that had it. But the fascinating thing about looking at old specimens, probably not in Boston, but in the 1950s when people were dissecting hearts, they didn't really care a lot about coronary arteries. Because, I mean, who was fixing these complex patients in the 1950s? So they've got lots of these specimens that have never had their coronary arteries dissected. So when you go and you dissect them, you find these abnormalities. It's really remarkable. So this one is entering, I think, has 2 separate origins of vessels. Yeah. Yes, sir.
Could you please go back to that one?
Yes.
Could you just talk about commissural alignment on that one?
Ah, sorry. Yes, thank you. I was going to make it separately, but I'll talk about it now. So the thing about transposition, so the intramural course comes off the right sinus. There's malalignment between the commissures. You know, our diagram that we have in our brains of the aorta and the pulmonary artery, there's a left and right facing sinus and a left and right facing sinus, and the commissures are beautifully aligned, which is usually the case. But in this situation, you can see there's malalignment of the 2 facing sinuses. This is the left and the right-facing sinus, the right and the left-facing sinus. And they're malaligned next to each other. You can see that clearly when it moves. Thank you, Girish. Okay, now this is the simple test. You just scan from the mitral valve to the pulmonary artery, and then you see this vessel running around the back of the heart, the circumflex. Okay, you didn't like that picture, I have others. There we go, there's it in short axis. Here's a scan from below, and you see the mitral valve, and then immediately before you get to the great vessel, you see the pulmonary, the coronary artery running in the groove here. And here's another one where there's a separate entrance of the vessels into that sinus of Valsalva. Now, single left coronary arteries will not have this posterior alignment. Actually, here's the left coronary artery, and here's this right sinus coming, the right coronary coming off the same sinus with a separate orifice here and running over the heart anteriorly with a separate conus branch running right anteriorly. Here's a specimen showing only one coronary artery in transposition, and here is one left coronary artery arising anteriorly from the great vessel. So it's clear that we can see these coronary anomalies, and I think what we did in our survey, we couldn't quite reach the Boston level of excellence. But what we started to do is we made two of our echocardiographers go and study the coronary artery. So what we did is there was a general study of transposition, and then after the Rashkin or the patient had been prepared, the next day somebody went up and spent another hour looking at the coronaries. And by doing that and making a specific effort to look at the coronaries, the diagnostic accuracy improved. So you don't want to do this in the middle of the night when you're tired and you've got a blue baby that you're trying to stabilize and put on a respirator and put on prostaglandins. You want to come back the next day when the kid's stable and quiet and try it under those circumstances. Okay, so here's a vessel that you can see running anteriorly off this sinus of Valsalva in transposition. And this is a patient with L transposition, so the origin of the coronaries is switched. So this is what I said about those things that Gerish brought to our attention. Malalignment between the cusps, high takeoff of the sinus of Valsalva, crossing the commissures, more common in double outlet, particularly with transposition VSD type physiology, and coronary running between the aorta and the pulmonary arteries. Okay, so here's another intramural coronary. There's the right coronary, and here's this intramural course coming off the same sinus, running across the commissure and towards the left. And I think it's fair to say that in our experience that the intramural course is more common with the left than the right coronary artery. Now, this is a paper by Tsifa. Actually, Tsifa is somebody called Bob Anderson. So what they did is they surveyed their patients with transposition to see what was the origin of the coronary arteries. And lo and behold, just as we see it in the left from the right sinus or the right from the left, the coronary arteries are usually high. So if this is the sinotubular junction here, as depicted by this line, you see the black indicate the intramural course, and at least 3 of them are well above. 1 is on, and only 1 would be in the sinus of Valsalva in the normal position. And I think that they've shown very nicely the different degrees of coronary exit from the aorta. Here is the normal, here's a minor intramural course, and here is a major intramural course. And the surgeons know about this and they know how to deal with it. So here's normally aligned commissures, and there are malaligned commissures. It's actually the same patient again, Girish, but we've done that before. So it wasn't that I hadn't recognized it. Here's a intramural intra-arterial course of this coronary, coming over here and running right through the great vessels and coming up here, and then running on the surface of the heart as a standard left anterior descending. Steve mentioned this in tetralogy, the dual origin of the coronaries, and showed it very nicely. Here's a surgical example of dual origin. I don't have an echo picture of that, but this is the one that really is the important problem. It's when the left anterior descending comes from the right and crosses the right ventricular outflow tract in tetralogy. I think we actually showed this in the tetralogy talk. But there is a beautiful example of a solitary big right coronary artery with the vessels coming off, both coming off from the sinus. Now, I spoke to Damien Bonnet, who's been looking at their coronaries in truncus, and he said to me something that is only typically what a provocative Frenchman would say. He said 100% of coronaries in truncus are abnormal, but the two series that have been published have shown largely that there are about 17 to 20% of coronaries in truncus arteriosus are abnormal. Well, okay. So the truth lies somewhere between the two extremes, as usual. But what I want to point out to you is here runs the coronary. It is running an intramural course for sure. And in fact, it's a high takeoff, just as you see in this specimen over here. Now, what is the importance of this for us as echocardiographers? Just to stay on the good side of the surgeons. Because when you have a type 2 truncus and you don't have a nice area where you can cobble off the vessels, in truncus your object is to take a piece of aorta to sew to the homograft and leave a hole. Now, if the pulmonary artery cut goes too close to the coronaries, it can slice through the coronary. And once you have done that, you actually have a dead patient. So you have to tell the surgeon, not that he isn't going to look at that very carefully, but he has to look at where the position of the coronary artery is to make sure that he doesn't cobble it up in the piece of aorta he's taking out to suture into a conduit. Now, the question about why there's an intramural course and whether that's dangerous or not, or is associated with sudden death, I don't have an answer to that question. Of course, there are other problems in truncus. Here's a giant conus branch. Here again is another intramural course here. So you see a large conus branch in the front on this patient here, and then another patient with a probable intramural course of that coronary artery. This I got from Dr. Shirali. It's a patient that they did something, I can't remember, it had an interventional procedure like an ASD or repair. And then during the course of this, they found, in fact, that there was a single coronary artery coming from an anterior commissure. And you can see very beautifully here, this, look, Girish, I even put your name down there. Eh? Okay. I asked Girish whether I could use this. He might remember that I did ask. And you see the two coronaries are rising anteriorly from the same sinus. And nothing happened to this patient. And lastly, you can look at the coronary arteries, as Steve said earlier on. You know what a left coronary artery looks like on echo? You know that it bifurcates early. It gives rise to the left anterior, the ramus intermedius, and the circumflex. And the right coronary is long, okay, and solitary. We've seen that all the time. So if you get a pattern like this and you see a bifurcating vessel coming off here, you may assume that there's really ventricular inversion as well, because the coronaries follow the ventricles. And indeed, this is a patient with ventricular inversion and atrial and ventricular arterial discordance, so-called corrected transposition, and the coronary arteries really reflect as well the morphology of the vessels and the ventricles. So I think that's it, yes. Thank you very much. Now, there's time for some questions.
Yes, only to understand. When I poker, I have
Yes, correct. That's right. A fistula. Collaterals. Yes, exactly right. That's what it shows on the angio. I didn't actually pick an angio to show you here. Yeah, you see it with the color Doppler. And I don't know, because that's been that way, there seem to be much more in the way of communications than we assume from what we call end arteries. The coronary arteries are considered end arteries. But somewhere about this congenital, and in the physiology, is the physiology of a fistula. Okay, the only problem with the left ventricle is that the fistula steals from the left coronary artery as it's draining into the pulmonary artery. And that blood, which should perfuse the left ventricle under high pressure, is running off into the pulmonary artery. That's what causes the ischemia. And the old-fashioned operation for this used to be to just, when they didn't do it, was to ligate it. And sometimes you could actually get kids to survive. Now, there are adults that have anomalous coronary artery recognized when they become symptomatic. I've seen them in the adult lab that I used to work next to.
The oldest one I saw was 55.
Yeah, I've seen a woman of 60 with an anomalous coronary. Sometimes nature is kind, and they make that orifice, and I think Steve showed that. The orifice is small. So the orifice becomes restrictive, so there's still maintenance of flow. And then, of course, when they get coronary artery disease, then they will become symptomatic from the fact that the flow is compromised now by atheroma rather than the fistula. So there are adults that can be pictured.
That's a general concept,
Yeah.
that patients who make it to adulthood or to adolescence almost always have some narrowing of the left coronary ostium,
Yeah.
which limits the runoff from the left ventricle and prevents such severe ischemia that they can survive to adolescence or adulthood.
Yeah.
But you saw the ventricle that I showed you in the patient that clearly had a stenotic ostium. The ventricle was very bad. It was dilated.
Yeah.
It had endocardial fibrosis. You know, so it's only partially protected.
I was a little surprised by the fact that all the ventricle doesn't there is not function all the ventricle.
Yeah.
And the right coronary territory too.
Yes.
And usually in the ischemia, cardiomyopathy in adults, you've got the posterior wall that works and the other part of
Yeah.
the left coronary that doesn't work.
See, I think what's happening here is that the steel is involving even the parts that are supplied by the right coronary, because that's where the communications are. Typically, the communications are between the posterior descending and anterior descending around the apex.
Yeah.
And so that takes away from the posterior septum, inferior septum. Between the distal right and the circumflex around the posterior AV groove. And so you lose part of the basal septum that way as well. And then across the anterior part of the heart, from the preventricular branches across to the anterior descending, you get a lot of collaterals. Those are the three main areas where you see collaterals. And so you get a steal from all of the left ventricle. Even sometimes a little bit of the right, sometimes a little bit of the anterior wall can be involved as well. But most of the time the right ventricle looks pretty normal. But it really does pretty uniformly involve the left ventricle, although the papillary muscles are probably the most severely affected. They're almost always thin
Yeah,
and
fibrotic.
and clearly have lost muscle.
Well, we're going to have another course sometime, and we'll do the first topic we'll do at the next course will be Epstein's malformation. I think that we're done for today. Now, I understand that there's a program evaluation. Have you completed the program evaluation? Well,
Everybody has it? Oh, okay.
because I can just go and ask
Valerie
Valerie,
without doing it.
Veronica, you can't leave without doing it.
I'm pretty